I thought that we ought to review where all this came from in the first instance, because we're trying to put together a lot of things about the management of ALS. It's interesting to see where it in fact came from. I think there were one or two of us who felt that what we really needed for patients was to be able to have a video that we could show them that dealt with one particular area, the need for non-invasive ventilatory support, and I felt we hadn't got a good video, an educational video. There turned out to be several other areas that would really have been of great help to us to have, and so we began to talk to the ALS Association about maybe helping us put that together, and from that has really come this project. The additional area that came out at really around the same time, which was the Academy's practice parameter, product of a lot of tremendously hard work by Bob Miller, who since he can't really speak objectively about it, it allows me to say a few wonderful words about what he did. For those of us who sat with him on that committee, he did a tremendous amount of innovative development work and produced a series of guidelines with regard to how to manage ALS. We all thought we knew how to manage ALS. The practice parameters, however, is evidence-based medicine and derives from published papers in the literature with regard to ALS, something that some of us were not and probably are still not terribly comfortable about, because it doesn't encompass all that we actually do with ALS. Nevertheless, the practice parameters as they came out in terms of how to make the diagnosis, how to break the diagnosis, how to present the diagnosis to patients and their families, the symptomatic management, the management of respiratory problems, the management of nutritional problems, and then end-of-life matters, palliative care. Those were the main areas that in the end your committee came through with, and I think they were really, it's a tremendous step forward for our management. Bob, why don't you tell us a little bit about the mechanism and the product and what you think we achieved and you achieved.
The one thing that I have to say is that it was very much a team effort with input from experts in neurology, from nursing, breathing problems, gastrointestinal problems, and a lot of input from people actually struggling with the disease and family members as well. And really, it's a synthesis of the world's literature and the evidence that is available to us that has been analyzed in a quantitative and proscribed kind of fashion. And so we're very proud of the output. It's a benchmark. This is a beginning. It is not the be-all and end-all answer to how to take care of people who have this disease, but it certainly represents an important start. And you've mentioned the 5 areas that were covered here, and we feel that those are the most important areas. Lots more still to do. Underlying the process, there were really 4 major assumptions about how we should proceed, and one of them is that we are only advisors. We're here to help people make decisions. That's the person that is struggling with the disease who makes the decision, and so empowering the person, the patient who's struggling with the disease, and acknowledging their autonomy and their self-determination was really one of the major issues. And the second point, which follows right upon that, is letting people know early enough, in advance of junctions in the road that are imposed by advancing disease, educating people about their choices. The practice parameter is really fashioned to help people at branch points in decision-making to be able to make the right decision, the best informed decision based on evidence that will help them to manage the disease most effectively. So the assumption is that we will provide that information to people well in advance of the branch point and make sure that they understand what the issues are. And then the next assumption was that we would provide a full continuum of care, that we would be with people from the beginning, from diagnosis, all the way through the later stages of the disease, so that neurologists and people who care for persons that have this disease would be able to provide the full continuum of care. And the 4th underlying principle is to be able to talk with people with the assumption that people may change their minds, so that revisiting important issues at least every 6 months or so, and talking about the issues involved in making decisions about those processes at the end of life, as we approach the end of life, that are covered under advance directives, that it's very important for physicians to bring up the issues and to discuss them in a recurring way. And then there were issues that we started to get into about how do you tell the diagnosis to a person with ALS. As far as I'm concerned, this is one of the most daunting tasks that I face in healthcare. Breaking this kind of bad news to people about this kind of disease is just very difficult. And so we were seeking ways of helping healthcare providers, neurologists particularly, to be able to tell the news in a way that would still leave room for hope. And so some of the evidence-based guidelines that came out of that are to make sure that we do this in person, and that the attending physician should himself or herself sit down with the family and with the person and take into account the cultural background and the educational background, and do it in a way that gives people time to prepare for this major sit-down and sharing of really very heavily emotionally charged information.
It's advisable, first of all, to see who the patient wants present when you're giving the news, to sort of check it out with them. Would they rather hear it alone? Would they rather hear it with loved ones present?
It's a really important point. Some people from different cultures actually feel strongly that that information shouldn't be shared directly with the patient, but rather it should be given to the family. Others want to be present, but don't want to hear all of the bad news. So it's very important to ask the individual whether they want to hear all of the information, for example, or whether they would prefer that this information be given to the family, to take all of that into account.
And that's something that, in fact, we have to feel our way through as we're doing things often in terms of the presentation. You can't necessarily give it all to the patient at any one time, and often you've got to draw back sometimes and present to actually to the family members sometimes rather than to the patient.
Yeah, I couldn't agree with you more. I think it's very much an individual thing. I prefer to sit down with the patient themselves. If they're family members that they want there, that's fine. But I really feel like my obligation is to that person. And give them a chance to ask questions. If you get partway down the road, you just can't script it all the way to the end of saying, and this is what I think is going on. You've got to give them, I think, a chance to ask, gee, what does that mean? Where are we going with this particular line of thinking? How do you leave hope for a patient? Because oftentimes they've sort of begun to understand what's going on. They've read the textbooks. They say, oh my God, I'm going to be dead in 2 years, or I'm going to be dead in 3 years. And I think most of us have the experience of patients who've gone on and on and on. They're sort of like the Energizer Bunny. They keep right on going, and they have a very good quality of life while they're doing it. And ultimately, it seems like everything we're doing here has to do with the quality of the patient's life.
Well, I always try to give people some of my own personal experiences that have come out of this. For instance, I always tell them I have one patient who is in his 60s who has had the disease for 40 years. He's still playing golf. He wears a brace on one leg, but other than that, he is really completely without disability. And that suddenly lifts up people's, my God, you know, what's different about him? I don't know what's different about him except that it was there naturally. I also tell them about that I have had 3 patients where it seemed to be absolutely classic ALS, and yet it arrested and then disappeared. And then there are a number of others that are in the literature who have a similar sort of situation. And then finally, and I think most of us have had this experience, there are maybe 5% plus of patients have a progressive disease to a certain point, and then it seems to burn itself out. Debbie, I think you were having some of that.
For the patient who's presenting early and who still has retained a lot of function, it is possible to cite those examples of very hopeful, very wonderful, optimistic outcomes. For the patient who's more advanced in disease, the challenge of how to give them hope when giving the diagnosis becomes more complex. And in those cases, I always try to review some personal history with the patient of what have they weathered in the past, what has been their life experience, how successful have they been with pain, with loss. I reaffirm their courage and their strength and my conviction that they'll do this beautifully.
Of course, I always discuss what's going on in research. I think it's so much going on in terms of finding out pathogenesis and recent discovery of SOD ALS mice, and so many new medication on horizon, and some are already clinical trials. Those are indirectly affecting, but I think it's a tremendous hope to the patient. Also, you have to show your commitment in taking care of the patient, and you have to show your interest, commitment, and also giving always appointment, next appointment, not say, why don't you call us if you have a problem? That's the worst way to do, and you really have to give appointment. And then I just agree with Deborah said, you even a very difficult stage, you have to present how you commit to take care of all stage, whatever you can do.
I think that's right. You can't let the patient feel like they're going to be abandoned after you've been given a long time to talk to them. One of the things that I do, which I think a lot of other folks do as well, is say, I know you're going to have questions after you leave here. Your family's going to ask you questions. Other people are going to ask questions. Write them down. Let us know. You don't have to wait until your next appointment, whether that's 2 months from now or 3 months from now. Get back in touch with us. We're not going to be just disappearing when you walk out the office door.
Rob, one of the outcomes of the practice parameter that you have taken some interest in is actually the handling of some of the problems of sialorrhea and the problems of pseudobulbar affect. Why don't you say a word or two about that?
Well, actually, that's come from my conviction that what we are doing is treating the quality of life of patients and trying to improve that in the healthcare sphere. I wanted to do a whole lot of things, but we ended up looking just at the problems of excess salivation leading to drooling, and figured out that in fact it really probably isn't excess salivation as much as they just can't handle the saliva that they produce. And it begins with getting excess salivation at night. Their pillow will be wet at night, and sometimes it goes on, and probably in about a quarter of the patients it leads to some drooling during the daytime. Very socially disconcerting. And it's something that I think all of us try to approach because it is something we feel like we can do something about. The problem came in when we went to the literature to say, gee, has somebody actually looked at this in a real defined way, using drug A versus nothing to see if that is an improvement? And in fact, there's very little hard data of that kind in the literature. There's a lot of suggestions. And so everybody's developed a practice paradigm which suits them as much as it's been proven in a scientific way. And so we're left with a lot of different types of approaches. Some people use Robenol, some people use Elavil or amitriptyline, some people use atropine. In some of the other kinds of diseases, we've used benztropine. And I guess one of the things that I like to use best now that seems to work for our patients is a patch, the so-called transderm scope, or what has been written generically as hyoscine, that is a patch that you put on every 3 days, and patients seem to do quite well with that some of the time, and it has to be individualized for each patient.
The other thing is, of course, the pseudobulbar problems, the laughing, the crying, and so on.
Yeah, that's really a tough one, because patients don't often volunteer that. Caregivers don't even volunteer that, but if you bring it up, they'll say, oh my goodness, I didn't even know that was part of the disease. You mean when she starts to cry in public that this is not just that she's being depressed, this might be part of the disease? And I think if you can validate that for the patient, validate for that for the family, they'll be very accepting, again, of some attempts to try to make that better for them. I'm not sure you can improve it entirely, but I think you can certainly make a huge difference in that, again, social context, quality of life type of issue. So the major approaches have been to use tricyclic antidepressants, so-called. In fact, Elavil is a very good one. Some people like using nortriptyline or Pamelor. The other side of that is the newer agents, the SSRIs, or selective serotonin reuptake inhibitors, of which everybody knows about Prozac. And it's not to say that this is some psychiatric problem. It's really trying to solve the facial manifestations that are so disconcerting to the people around them. And in fact, the caregiver often has more problems with it than the patient.
Along with being emotionally disconcerting, the affect interferes with speech, interferes with breathing, interferes with the ability to chew and to eat, and really, when you relieve the symptom, you make life easier for the patient and function greater.
One of the things that that I try and tell the families is that this is really involuntary, that in fact it is not the patient intending or even the patient's emotional state demonstrating itself. It really is, and I use the term emotional incontinence. Now, some people are not happy with the term emotional incontinence. I use the term because it is really an illustration. If you draw the comparison with wetting yourself, you didn't intend to wet yourself. You just didn't have the capacity to control it. It was not that you had any volition. Now, tell us why you don't think that's a good term.
It's not very attractive. But the other thing that occurs to me is that it is excessive emotionality, both in the laughter sphere and in the crying sphere, and so I prefer to think of it in that way, but I have to say that your label is very graphic.
Well, I think there's actually a common ground between the two positions. I think when we talk amongst ourselves as physicians, we really don't want to use the term incontinence because that means something different, because what we're trying to do is be very precise about describing this affective response. But when we're talking to patients, as Wally's suggesting, gosh, that's graphic enough to get their attention, and even if it's not medically precise, it may still be useful. I must say I don't use that term in front of patients, but I have the same response Bob does.
I explained to medical students, actually, pseudobulbar manifestation, forced laughter or forced crying is a disinhibition of respiratory, laryngeal, pharyngeal, all those muscle involving animals' vocations, vocalization. So essentially, muscle of controlling respiratory muscles, laryngeal muscles start twitching and going either way, going to crying or laughing. It's a very similar phenomenon. And that is a disinfusion. It's not really incontinence. And my mentor kept saying incontinence, wrong word. So that's the reason I don't like the word.
Actually, I use a different illustration. I say, you know, if you've got a 6-month-old baby and you go up there and you smile at them, they'll smile, and if you make a frown, they'll go to a frown instantaneously. And that's the sort of lability that you see in a patient's facial expression as well, that they can go from what seems to be a laugh to what seems to be a cry, or a smile to a cry, very quickly.
Right. One of the other areas that that we dealt with in the practice parameters was the area of nutrition and enteral feeding, or peg tube placement, and I thought this was a really major advance in terms of our management of patients and awareness of it and so on. Dr. Mitsumoto, Hiroshi, you did a great deal in this area. Would you like to tell us a bit about it?
Sure. Actually, I cannot remember exactly how many references we reviewed first time. I think it's probably 600 to finally 50, 60, and finally 20, 30 references. But I think it's a surprisingly very little written in ALS, except for very few important papers, although retrospective studies. So based on those evidence-based, look at all those quality of the papers, study, quality of the studies, and so forth, what we came up is we have to follow patients very carefully. Every 3 months, we have to check how their nutritional status, how they eat food, and if it's necessary, you have to work with the nutritionist, checking with their oral intake, change food form to more palatable, edible, easily manageable food form. And then still every 3 months checking weight. If or when, patient develops trouble with swallowing and trouble with handling of food, that's almost the time you start thinking of way to continue nutrition. Let's say percutaneous endoscopic gastroscopy, we call PEG, which is very practical, neat, and convenient and clean method, and very effective. And that's what I use these words to the patient and to consider. Really, I think it's a proactive approach is very important, Based on those papers, we came up the PEG should be placed when the patient becoming symptomatic. I mean, the patient when having trouble with swallowing. But the important thing is forced vital capacity or for vital capacity should be above 50% of predicted. And the reason is patient has to lie down for procedures. Minor sedatives should be used to put simple gastroscopy, and that sometimes create trouble postoperatively, and that's the reason we recommend strongly if PEG is placed, vital capacity should be certain level.
How do you even get to that point, though? Sometimes patients really don't want to give up that autonomy. They say, I'm really not interested in having that PEG placed. I don't want to stop eating.
Everyone faces the same problem. When we talk about the PEG or tube in the stomach, majority of people says, no, I'm eating okay, and I don't want to talk about it. And really, I think it's putting something tube through the stomach is sort of reprehensible idea. Yet, you really, I think this is coming good education and talking to the patient, and still they can eat, even has a PEG tube in, and a lot of positive way to discuss with the patient. Yet still that's true, sometimes going into a very difficult stage.
This is an area where everyone has a different approach to it. So Debbie?
I also like to stress the fact that they'll still be able to eat by mouth, and that the tube is there for additional hydration, for medications, and just for supplementation. But what I find really makes people want a tube is when they go to a support group and they meet someone who has a tube. That personal testimony, looking at the tube, feeling it, touching it, saying, is your life easier? That makes a much more convincing argument than anything that the physician can say.
I really agree with that, and I want to emphasize something that you said earlier, Hiroshi, and that is that there is evidence that when people are having so much difficulty swallowing, that fatigue is a big issue, that they're really starting to lose substantial weight, and that the eating process is becoming a labor. Their quality of life can be improved, and their survival can be substantially lengthened by the evidence that we have if it's placed early enough to avoid the risks that you alluded to when the breathing capacity falls.
I think that's you're bringing up another very important issue. You mentioned those fatigue issues. Usually how I discuss with the patient is, how long does it take to finish a meal? And this is a very good indicator. They say 30 minutes, 45 minutes, even 1 hour. Then you ask, how do you finish meal? Do you finish meal because you feel full or you feel tired? And usually those patients who continue eating, usually they stop not because they feel full, because just simply fatigue. Another very important thing is you need to discuss with the patient is that ALS is a wasting disease. I mean, wasting of muscles, atrophy, so the body weight lose, and malnutrition is clearly cause muscle weakness, which is shown many times in concentration camp and military volunteers, and also anorexia nervosa. So really, when the patient has muscle wasting disease, good nutrition, of course, and fluid intake is crucial to maintain strength.
And I think one of the points that you need to make to the patients is, in fact, that the disease accelerates if they lose weight, and really is very similar to the problem in failing vital capacity. And in fact, probably vital capacity and respiratory things is something we should now move on to talk about. And Debbie, you've paid a lot of attention to that. Do you want to tell us your approach and what came out of the practice parameters?
When I first started working in ALS, I found that I was almost afraid to hear that they were having problems breathing, because I had a very nihilistic sense about what we would do if they had problems breathing. That's really not the case anymore, and I find that I'm very proactive in searching for symptoms. In terms of difficulty with breathing, patients will have a loss of respiratory muscle strength, just as they'll have a loss of any other muscle strength. And it's very important to separate out whether they're tiring more quickly when they're exerting themselves, more subtle things such as unable to really feel restored with sleep, awakening frequently during sleep. things that they would not identify as being shortness of breath, but may actually be symptoms of decreased vital capacity, decreased breathing reserve. Because of the fact that there is so much to offer, and that offering it early probably maintains energy, definitely increases lifespan, and at the same time decreases that further drop, that further atelectasis, that further decrease in lung volume. It's important to search for the symptoms, document them early, and then start them on non-invasive ventilatory support as soon as you can. And the ideal time to start them is actually when they're sleeping during the dream stage of sleep, REM sleep, which represents a great physiologic challenge for the respiratory muscles, and also is the time of our day when our diaphragm has to do the breathing alone without any aid from the accessory muscles. And so non-invasive ventilatory support is a great boon to patients. Patients claim that they sleep better, they awaken feeling like they've gotten a good night's sleep, they have better exercise tolerance, they're more alert during the day, and they actually feel more stable, sometimes for months and years, so that it can be wonderful.
Well, we were just talking about how a lot of people are not very eager to have a tube placed in their tummy. How do you get over the resistance that a lot of people have to the idea of having a machine for breathing?
Well, I usually joke with them a bit about it and chide them into it a bit, and in the end, I ask them to try it for a month. And if I can get them to try it, if you can get them to go along with you that far, they'll usually start feeling better, and then they'll be compliant.
How do you do it, Bob?
Well, I think I introduced it a little bit differently in the sense of one of the things that we do that I think all of you do is measure their vital capacity every time they come to clinic, even years before they eventually may need ventilatory support. And so it can't come as any surprise to them that we're worried about this and that this is something to think about. And sometimes they've even brought it up at that point. What should I be doing? If my breathing capacity is going down and you're worried about it, what should I be doing about it? And I think we have a greater opportunity to make them partners in that particular process.
One thing, though, is that vital capacity can sometimes be falsely reassuring, so that often patients will have a very good vital capacity, and yet they'll desaturate during sleep, or they have a very high vital capacity because they were smokers years ago and they actually have hyperinflated lungs, and it doesn't mean that they have good respiratory reserve at all. So that although the vital capacity is a nice indicator, it is not an early indicator.
Somebody made the point earlier about that the patient with a PEG is probably the best advocate for the placement of PEG, and I think the same thing goes actually with regard to non-invasive ventilatory support, because I have, for instance, a patient who is just a tremendous advocate. He lives now almost all the time with his BiPAP machine, but he's a public speaker. He goes around and raises money for our ALS Research Foundation and so forth. And he, at the same time, says, this is the answer. I would be on a ventilator, I'd be dead. And the fact that somebody can be independent with that is really tremendous. Bob?
Yes, I think that what you're illustrating is something that Bob pointed out earlier on, and that each patient is autonomous, and they're going to have their own approaches. And maybe some of the patients who I say are sort of partners and volunteer to do this with me, and then there are other patients, as Deb described, who take some convincing, and another patient who's getting successful treatment is as strong an advocate, I think, as anybody else, and that goes back to the whole point of having an individualized program for each patient.
There are patients who make decisions that you and I might think were not the right decisions, and yet they make them, and that's their right to make them. And though we might think it was the right thing to go on BiPAP or have a PEG tube placed or something like that, if that's their decision, that's their decision, and it's ours reason to support. Hiroshi?
I certainly agree. I think we all respect the patient decisions, but we are really obliged to present all information, data, and what's available, and then after informed decision, if they make, that's their decision. We have to respect. One thing is also I'd like to discuss is that non-invasive ventilator, is a very effective way, one step before really going into invasive ventilation.
I think that's really where patients will sometimes make decisions that their individual physicians and sometimes family members don't agree with. Right. When a patient has clearly decided that they do not wish to die a respiratory death in ALS and that they wish to be on a ventilator, the task then becomes not one of trying to talk them into or out of what their decision is, but to try to assess what their capacity and their family's capacity is for having that be a good decision for them. And I do try to guide patients in terms of realizing that if they choose invasive ventilation with the tracheostomy, that they're necessitating nursing care, that they're converting family members into at least part-time nurses, and that they're really taking on a big expense. And that may be a wonderful choice for them, for completing something in their lives, or maybe for watching their children grow up. But it is a decision to be made thinking of the family and the individual and coming to a group consensus.
Well, we sort of have a saying around our clinic that the patient doesn't get ALS, the family gets ALS, and you're right, we do have to take the family into consideration. And it's a tough problem to handle sometimes between patient and family. You don't want to get too much in the middle of it, but at the same time, I think you're right, you do have to let the patient voice their opinions and not get overwhelmed by what the family wants or vice versa. And I would see the other side as being problematic too, the patient who simply says, look, I don't want any sort of ventilatory support, but I still want you there as my doctor. I still want you to help me. And they're afraid sometimes that you're not going to be there if they don't do something that you agree with.
I think it's important that you always stress to the patient that it really is their decision and that you're there to guide them and to give them information and that you'll stay with them regardless.